So, to begin the session, the first talk is by Dr. Suman Bhandari, who's going to talk about refractory angina and the current management perspectives. Over to you, Dr. Suman Bhandari.
So, good afternoon, friends. It is a pleasure to start the proceedings of this 2020 CSI conference, and my uh, talk for this 34th annual CSI is on refractory angina, hope for the hopeless. So, what is actually hope? Hope is feeling of wanting something to happen and thinking it will, a desire with expectation of obtainment, to cherish a desire with anticipation, expectation and desire for a particular thing to happen. And hopeless is not susceptible to remedy or cure. This is one of the good review articles which came in January 2020 and talked on the same refractory angina, but was focused on non-pharmacological technologies, which I will also cover. So, what is refractory angina for our understanding? Long-lasting symptoms for more than 3 months due to presence of obstructive coronary artery disease, which cannot be controlled by escalating medical therapy with use of second or third line pharmacological agents, bypass grafting, or stenting, including PCI of CTO. So, this is based on the European 19 guidelines for chronic coronary syndrome. The good thing about refractory angina is, despite its name, it has a modest mortality of just 3.9% at 1 year and extremely good long-term follow-up of about 78% at 9 years. And of course, it does give you a lot of needing to handhold the patient for this long time. We have to look at how to optimize medical therapy, and these are some of the things which are all of us do follow. We correct anemia, we combine many of these drugs, and look for patient education, other risk factors, smoking, etc. And of course, these are the anti-anginal chronic coronary syndrome recommendations. And this is, of course, the older 2002 refractory angina, but is quite pertinent as well. So, medical treatment of symptomatic patients requiring more than one drug, and timely review of patient's response is also class 1 indication, nitrates, and first line beta blockers, calcium channel blockers, and then, of course, a lot of other agents as well. I think this is a very good module to understand where we have to improve the supply or the demand. The supply is dependent on hemoglobin, on blood rheology, on coronary flow, where coronary sinus reduction would be applicable, coronary inflow, where you have angiogenesis or EECP or PCI or surgery, and of course, looking at oxidative stress by allopurinol, which looks at the demand, trimetazine, which looks at the pathway metabolic modulation, ranolazine, and heart rate contractility beta blockers, etc. So, all these factor into how we're going to control refractory angina. Just to take a word that allopurinol has got more visibility now with the evaporate trial, etc. We are aware of some of the benefits of these metabolic modulators, and also ivabradine, etc. All this, I would like to just make you understand that when you look at ATP, which is the pathway for all these metabolic modulators, 30 kg of ATP is used every day in the body. So 30 kg. So look at how much metabolism is important for the body. So this is the Kaplan-Meier curve over 10 years for these refractory or no option angina patients. Not too bad, considering what we think refractory angina should represent. So it's prevalent in 5 to 10% of stable coronary artery disease. Many emerging therapies have been found to be beneficial in refractory angina. Some of the studies showing the incidence of refractory angina, and various models to show that heart and the brain as a receptor for pain are interconnected. Some people may have angina and no pain. Some people may have mild angina or mild ischemia and severe pain. So a lot of depends also on the brain. And that's been the target for synthetic denervation. That's been also the coronary sinus reducer, as I will allude to, is also one way to address myocardial perfusion. And of course, subcutaneous electrical nerve conduction to change your sort of pain receptors. These are some of the key non-pharmacological therapies for refractory angina, and including spinal denervation, including the even extracorporeal shock wave myocardial revasculation from outside. Some randomized trials showing some benefit from the German trials. Cell therapy for refractory angina has shown some improvement in exercise time, angina, and mortality compared to placebo. And it needs, of course, more work on it. We are aware of the reducer, which also was tried in India initially in the first 15 patients. India was one of the sites. And now randomized trials have shown that when you sort of block the coronary sinus, you redistribute the LAD flow, making it more subendocardial and improving perfusion. Some benefit has been shown. Also, EECP has been used for a long time and has a class 2B indication in refractory angina. Since these are European guidelines and shows ECP based on these trials, number of patients, extracorporeal shock wave, coronary sinus reduction, 104 patients in the Coursera trial, spinal cord stimulation, transcutaneous electrical neural stimulation, symptectomy in about 65 placebo-controlled patients, gene therapy, autologous cell therapy. And based on this, the guidelines state that EECP for patients' relief is 2B, level of evidence B, reducer also 2B, evidence level of evidence B, spinal cord stimulation 2B, B, and of course TMR, which was in vogue earlier on, is now a class 3 indication. And there are some gaps in the evidence. We need larger randomized trials, more registries to define role of additional therapies, and identify specific subgroups to decrease non-responder rates and a certain benefit beyond potential placebo effects. And in conclusion, I would like to end by saying that use of refractory angina and not no option therapy angina makes us look for newer and better therapies and not totally be hopeless. And awareness and acceptance of this new paradigm is basic to improve the quality of life of this large subset of patients, which are about 5 to 10% of the chronic coronary syndrome group. And I think hope still exists, and it's not a hopeless paradigm. Thank you. Thank you for your kind attention.
Thank you
Thank you.
so much, sir. We can have one or two questions, sir, as suggested by most of the speakers, so that it is carried on comfortably. Dr.
Yeah,
Bhargav,
yeah.
you can take over, please, sir.
Yeah, Dr. Suman, like, what about the AV anastomosis in the iliac artery?
Sorry?
Like, AV anastomosis in the iliac artery and vein. So, that is also one of the treatment for
Sorry, I'm not aware. I have not come across.
because it increases the flow by about 800 ml. So obviously what happens is it decreases the load, the afterload, and that is how it helps in reducing the effort angina. This is also used for even in patients who have resistance hypertension. Like if hypertension is associated with refractory angina, there also if you do, so the load basically reduces and it is beneficial in those cases. Like
So what are you doing with this? You're connecting the iliac artery and the iliac vein.
yeah, and you have a like it's not stent, but it connects the artery and the vein.
A shunt, like a shunt.
Yeah. So it basically the venous flow reduces the afterload. So
No, but
you have
shunt,
refractory.
Dr.
shunts
Suman,
like you make in, for the renal usually increase the cardiac output. Any shunt will increase the flow, not reduce. I don't know if
Yeah,
we can discuss that. That's one point. But if there are more questions, we can take that.
Sure. Bhandari, in your routine practice, how do you go about these steps? Like, what do you want to introduce first, second? Any serial number you follow? Your preference for a patient with refractory angina?
I think nitrates, beta blockers, and adding calcium blockers if the heart
First
rate
step is drug therapy, enhancement of the drug management.
That's what I'm saying. That's what
and then the other things which we have enumerated.
So
what is your personal preference?
You want to say non-pharmacological?
Yeah. What is your personal preference?
Well, no, first, see, most often it is EECP. So EECP is something which, when you cannot do angioplasty or you cannot do surgery. So EECP is, I think, the best. Of course, you must look at correctable things like anemia. You must look at thyroid. You must look at other if the heart rate is still not controlled. So looking at both preload, afterload factors, and of course EECP, coronary sinus reduction. I have not personally, done that.
We have done some cases in India, coronary sinus reduction.
I think it was done few cases in Ahmedabad, and Dr. Seth is in one of the initial papers, which was started in, this is from Israel. Israel group did the first trial. And now there are 3-4 randomized trials. So coronary sinus reduction therapy, and quite often you're not targeting the CTOs. So if you're doing, and I think one of the things I came across reviewing is that every time you do angioplasty, 50% or 30% may have angina despite opening up the arteries. And you must remember that the resistance is most often dropped, not at the epicardial level. Yeah. It is from the arterioles to the capillary where the 95% resistance or, the sort of reduction in the flow happens.
Dr. Suman.
So even 50% of people who have corrected, angioplasty done may have some acetylcholine induced spasm at that site or some other artery. So some epicardial spasm, but 30-40% may have your, microvascular angina. So we may feel that we have done everything, patient may still have angina, and that's where IFR or flow, measuring coronary blood flow And then I think
Suman, we are
for ACE inhibitors, ARBs will be important.